Ever thought about the hidden electrical system inside your heart? Imagine a tiny glitch there causing unexpected surges. Well, that's kind of the world of long QT syndrome, or LQTS.
Yeah, exactly. You can think of LQTS as a sort of genetic hiccup in the heart's electrical rhythm.
Okay.
And on an ECG, we actually see this as a prolonged QT interval. That's the time it takes for the heart's lower chambers, the ventricles, to recharge after each beat.
Right, and
Normally, that corrected QT, the QTC,
uh,
it should be less than 430 milliseconds in men and less than 450 in women.
and why does this slightly longer recharge time matter so much?
Well, because it can actually set the stage for some really life-threatening heart rhythm problems.
Yeah.
We're talking ventricular tachycardia, ventricular fibrillation.
Which can lead to sudden cardiac death.
Precisely.
So, okay, our mission today is to really sort of nail down the essentials of LQTS, what it is, why it happens, how it might show up, and crucially, what we can do about it.
And it's quite interesting, actually. The most common types, LQT1 and LQT2, they often stem from issues with a specific potassium channel. It acts like a gatekeeper for the heart's electrical flow.
Okay, let's dig a bit deeper then. So LQTS is fundamentally genetic, affecting the heart's electrical side.
Hmm.
And this stretched out QT interval, that's what predisposes to those serious ventricular arrhythmias.
That's the core issue, yes. But while the underlying problem is this electrical instability, the triggers for actual symptoms can really vary depending on the specific LQTS subtype.
Ah, right, the subtypes.
Yeah, we often focus on let's say, the big three, LQT1, LQT2, and LQT3.
Okay, and each has its own sort of danger zones, its triggers for those fainting spells, the syncope. Let's start with LQT1. What are the key triggers there?
So for LQT1, exertional syncope is pretty common, and there's quite a strong link with swimming, interestingly.
Swimming.
Yeah. Here's a quick memory tip, maybe a bit grim. Think of someone winning first place in a race, but then something goes wrong, often in the water.
Huh, that's definitely memorable. Okay, LQT2, what should we be looking out for with that subtype?
LQT2, that's often triggered by emotional stress, general exercise, or even sudden loud noises, what we call auditory stimuli.
Okay.
So you could think of it as too many stresses, emotions, exercise, sounds. They can all be culprits.
Got it. So LQT1 in swimming, LQT2 and various stresses. What about LUT3? What makes that one different?
LQT3 is a bit of an outlier because events often happen at night or, just when someone is at rest.
Peaceful times.
Yeah, you can picture the third subtype striking then.
Okay, so the main driver behind LQTS is these inherited genetic mutations affecting the heart's ion channels, the tiny electrical controllers.
Especially those involved in repolarization.
Repolarization, that resetting phase after each beat.
Mhm.
But you mentioned earlier, it's not always inherited. It can be acquired too.
That's a really crucial point, yes.
Yeah.
Acquired LQTS can pop up from a surprisingly long list of medications.
Oh, really?
Yeah, and it's not just heart drugs either. We're talking certain antibiotics like erythromycin, some antimalarials, chloroquine, terfenadine, even some psychiatric meds like tricyclic antidepressants and certain SSRIs like citalopram,
Wow.
and others too like methadone, haloperidol, ondansetron. It's a really broad spectrum.
That's actually quite alarming how many common drugs could potentially cause this. What else can lead to acquired LQTS?
Well, electrolyte imbalances are key, specifically low levels of calcium hypocalcemia, low potassium hypokalemia, and low magnesium hypomagnesemia.
Right.
A helpful little reminder for exams, perhaps. Low cal, low pot, low mag can spell trouble.
Good one.
Also, certain heart conditions like a recent heart attack, acute MI or myocarditis can do it. Even neurological events like a subarachnoid hemorrhage and severe hypothermia.
And there are also some congenital syndromes that bundle LQTS with other things, aren't there?
Yes, exactly. You have conditions like Romano-Ward syndrome, that's LQTS but without deafness. And then there's Travell-Longielsen syndrome, where LQTS comes with deafness.
Ah, so the hearing loss is a key differentiator.
It really is.
Okay, so summing up the risk factors, we've got family history, those genetic mutations, a whole range of medications, low electrolytes, maybe some existing heart conditions. And interestingly, female gender seems a bit higher risk for LQT2 specifically.
That covers the main ones, yes.
Yeah.
Now, pathologically, just very briefly, this prolonged repolarization can lead to these things called early after depolarizations, or EADs.
Okay.
Think of them as little electrical hiccups, the heart cells firing off a bit too early. These can then trigger a really dangerous arrhythmia called torsades de pointe.
which looks like a twisting ribbon on the ECG.
Exactly. And that can unfortunately degenerate into full ventricular fibrillation, VF. The precise mechanism, how the misfiring happens, it does differ slightly between the LQTS subtypes.
Okay. Now, really important for exams, if a clinician suspects LQTS, what else should be on their differential diagnosis list? What are the lookalikes?
Absolutely vital this. You need to consider things like Brugada syndrome, another channelopathy. Also, catecholaminergic polymorphic ventricular tachycardia, or CPVT.
Right.
Short QT syndrome, the opposite problem in a way. Then, simple drug-induced QT prolongation that isn't congenital LQTS, electrolyte issues causing QT changes on their own, and of course, underlying structural heart diseases.
That's quite a list to work through. So how common actually is LQTS in the UK population?
The estimates vary a bit, but generally it's thought to affect around 1 in 2,000 to maybe 1 in 10,000 people.
Okay.
And it's important to stress it can be diagnosed at any age, from infancy right through to adulthood.
Right. So let's talk presentation. How does LQTS actually show itself? What symptoms might someone notice, and what signs might a doctor pick up?
Well, the classic symptoms are syncope fainting spells and sometimes even seizures, which can be misdiagnosed.
Ah, okay.
These often happen during physical or emotional stress, as we discussed with the subtypes. Patients might also report feeling palpitations, like a fluttering or irregular heartbeat.
And those triggers can point towards the specific subtype, like the swimming for LQT1.
Exactly. And tragically, in some cases, the very first sign can be a cardiac arrest or sudden cardiac death.
A devastating first presentation. And what about the signs a doctor might find?
The absolute hallmark is that prolonged QT interval on the ECG once it's corrected for heart rate, the QTC.
Right.
You might also see some unusual T-wave shapes, maybe T-wave inversion or notched T-waves. Sometimes it's just picked up incidentally on a routine ECG, or maybe through family screening after someone else is diagnosed.
And family history is key too, right?
Oh, absolutely. A family history of unexplained sudden death, particularly at a young age, or known LQTS in relatives, is a major red flag.
So if LQTS is suspected based on symptoms or family history, what are the next steps? What investigations are typically done?
The ECG is number one, obviously, with careful QTC calculation. Then we'd often use Holter monitoring, that's a portable ECG worn for 24 hours or longer to try and catch any intermittent arrhythmias.
Makes sense.
Exercise stress testing, so getting the patient on a treadmill while monitoring their ECG, can sometimes provoke the QT changes or arrhythmias, especially in LQT1.
Okay.
For suspected LQT1, sometimes an epinephrine infusion test might be used in specialized centers. And then, really importantly, genetic testing. Looking for mutations in the known LQTS genes helps confirm the diagnosis and pin down the subtype.
Right, confirming the specific genetic cause. So how is LQTS managed once diagnosed? What's the treatment approach?
It's definitely a multifaceted approach. Lifestyle modifications are really important, so avoiding known triggers, like really strenuous exercise for some types, or intense emotional stress, staying well hydrated, managing electrolytes.
Avoiding dehydration and those low electrolyte levels.
Exactly. Then medications are key.
Yep.
Beta blockers are generally the first-line treatment. They help calm the heart and reduce the risk of arrhythmias.
Okay, beta blockers. Anything else?
In some situations, sodium channel blockers might be considered, depending on the subtype and specifics. For individuals deemed high risk, maybe they've already had a cardiac arrest, or have particularly worrying features, an implantable cardioverter defibrillator, an ICD, might be recommended.
The ICD acting as a safety net.
Precisely. It monitors the rhythm and can deliver a shock if a dangerous arrhythmia occurs. Genetic counseling for the patient and screening for family members are also absolutely vital parts of management.
And avoiding certain drugs.
Critically important. Maintaining an up-to-date list of drugs that prolong the QT interval and strictly avoiding them is essential for anyone with LQTS. There are online resources like Credible Meds that list these.
Good point. So what's the long-term outlook, the prognosis for someone diagnosed with LQTS?
You know, it really does vary depending on the specific subtype, how severe it is, and crucially, how well it's managed.
Right.
With the right treatment, beta blockers, lifestyle changes, maybe an ICD if needed, many people can live pretty full lives with a significantly reduced risk.
That's encouraging.
It is. But it's important to be realistic. Even with treatment, the risk of sudden cardiac death isn't completely zero, especially if the condition isn't optimally managed or if triggers occur. Adherence to treatment and follow-up is key.
Understood. And finally, just to round off, what are the main complications we worry about with LQTS high-yield points here?
The big one, of course, is sudden cardiac death. Then you have the ventricular arrhythmias themselves, VT and VF. recurrent syncope or seizures can significantly impact quality of life and just the ongoing risk from those arrhythmia-triggering events we've talked about.
Okay. So to kind of wrap things up, long QT syndrome, it's a genetic electrical heart disorder, can have really serious consequences. It's marked by that prolonged QT interval and this increased risk of potentially lethal arrhythmias, often triggered by specific situations.
That's a good summary. And recognizing those different subtypes like LQT1, 2, and 3 and their typical triggers is really important.
Yeah, and also being aware of the acquired causes those medications, the electrolyte issues,
Yeah.
and understanding the management from lifestyle and beta blockers up to ICDs when needed.
Absolutely. And look, understanding long QT syndrome is definitely crucial for your MSRA exam.
For sure.
For more in-depth resources, practice questions, things to really help you master this and other key topics, definitely head over to passthemsra.com and also check out freemsra.com.
Great resources.
Good luck with the revision.